Good morning, all. I believe my voice is audible to everyone, so you can help me improve my interaction by your chat room. So we already have a speaker, so let me start by introducing a conference first, and then I'll introduce the esteemed speakers. Sorry for the interruption. So this will be our first online conference, and we are focusing on oral health improvement strategies for Asia. So our focus is on Asia, and we are trying to identify the best practices which can help us identify the best practices to improve the oral health, in particular to Asia, as well as it can be applied globally also. For this, we have started this, and I'm thankful for our university, International Medical University, which helped us host this conference. So this is what you will be having, and we have lined up a few symposia. So the first symposium will be on the elderly, the oral health policy, which could help us improve the oral health of the elderly. So we have two speakers lined up for it. One is the first speaker, who is an expert in this, and he'll be giving an expert overview of this topic, is Professor F.A. Clive Wright from Australia. Right? So allow me to have a break here. So before I go on introducing the speaker, because I want to put up the program outline first. And as we wait on for the program outline, I'll like to thank our sponsors, QNM and CAVO, who had been very helpful for us in organizing this conference. They are the main sponsors for us. One is QNM, and these are the slides of QNM, which will be shown in between our symposia. I believe that we won't break our symposia to show our advertisers, but definitely we acknowledge the advertisers. And the other sponsor is going to be CAVO. This will be our other sponsor who helped us organize this conference. And our program outline is on. And let me briefly tell you what we are expected to be seen in this day. So firstly, we have the oral symposium, improving the oral health of older people. We have two experts in that. First expert will be Professor F.A. Clive Wright from Australia, and followed by Dr. Rahul Nair. First speaker, Professor Wright. So Professor Wright, I believe you will be able to see him. I'll just give a brief introduction, because the full introduction will take the whole symposium for us. He's from Australia, Professor F.A. Clive Wright. Prof, you correct me if I'm wrong in any way. He's from Australia. He is Associate Director, Oral Health, and a Clinical Professor, Center of Education and Research on Aging. He is very much interested in aging. He is from the University of Sydney. His current institutional affiliation is Concord Clinical School and Faculty of Dentistry, the University of Sydney. Previous positions have included as Professor and Head, School of Dental Sciences, the University of Melbourne. He has been the Chief Advisor for the Oral Health, Ministry of Health, New Zealand. He has been the Chief Dental Officer, Ministry of Health, NSW. His main area of expertise is dental public health, population oral health, and geriatric dentistry. His talk would be on improving the oral health of older people, a population health perspective. Now I hand over this podium to Prof. Clive Wright. Thank you, sir. Over to you.
Good morning, and thank you, Shaju, for your introduction.
So you can move it.
Yes, gotcha now. Brilliant stuff. Okay, at the wrong arrow, that's why. My apologies, everyone. So this slide just illustrates what I wish to talk to you about in the session. First, I'll look at some of the demographic changes in the population worldwide and the changing patterns of community oral health needs and the oral stations. I will also try and make some international and regional comparisons, but I'll draw mainly from my Australian experiences and the Australian evidence base. In the next section, I will look at health changes occurring within ageing societies, some of the principal concepts in geriatric medicine and geriatric dentistry, and I'll especially focus on frailty, capacity to make decisions, and things like the impact of accumulating chronic diseases and how we can build some better processes for caring for older people. Behind all of what I will be talking to you about today is this overarching philosophy and understanding of our roles as dental professionals. It's in a very complex, globalized world where our relationship with our patients do not occur in a vacuum. The influences on our patients and on us as dentists underpin everything we try to do to improve oral health of specific patients and groups of patients such as the elderly. So what we have to recognize is all these interacting factors that are occurring when we organize and discuss dental options with our patients, and how we interact with all of the other stakeholders, be they family, be they agencies, be they allied health workers, government and policy bodies, and our profession as well. So just remember these things at the back of your mind when you are thinking of dealing specifically with an individual patient. Let me just got to go to the right button here. So to start off, the data in this slide is taken from US international census data and simply illustrates the growth of the global population from the 1950s through to 2050. We currently have a global population of some 7 billion people, but by 2050 this will grow to around 10 billion people. Perhaps of greater relevance is the population projections for our region of the world. By 2050, India and China will have around 1.5 billion people. Indonesia will have grown to a population of just over 300 million, with Vietnam outgrowing Japan to more than 120 million. And the significance to those of us working in health and health service policy is the accompanying change in population demographics. It's very nicely illustrated in this slide taken from the United Nations and US report, which shows that in 2015 the balance between child dependency and age dependency crossed over, such that our entire infrastructures and support systems will need to change. As you can see here, where the lines cross, the blue line is the growth of the older population and the red line is the decline in children. And we are seeing this in both low income and in high income nations. Just to illustrate this more starkly from our Australian data projections, the number of those 85 years or older in Australia will increase by 5 times by 2050 and by 12.5 times for those 100 years or older. So the question for us in the dental profession is, are we ready for this dramatic shift in demography? And are we prepared for the changing oral health needs of older people? Again, international data, and this slide is taken from the US National Institutes of Health in 2016. It shows a rapid decline in the rates of those who have lost all of their natural teeth and rely on dentures for function. These projections show that in the USA, by 2030, less than 15% of the population will have no natural teeth. Our Australian data are showing the same trends, a rapid decline in those with no natural teeth. Our current study in Sydney on men 75 years of age and over is actually lower than the predicted value for those who do not have any natural teeth. Our study shows the rate of edentulous in men over 75 is less than 15%, and this data was collected in 2015 and 16. This slide is from Professor John Spencer. I'll try and point out the column here. What I want you to focus on is this column here, those that are over 65 years of age. As you can see in this column, the actual number of teeth in Australian elders will rise sixfold in the 3 decades from 1989 through to 2019. There will be an increase of some 60 million teeth in Australian elders. All these teeth are at risk to dental caries and periodontal disease. What is probably more important from a population perspective is that oral health risks are not equally distributed across populations. This recent New Zealand study of older people from different backgrounds and living in different settings nicely illustrates the diversity of different outcomes for different community subpopulations. Looking at only one health outcome, the prevalence of untreated dental decay, living in residential accommodation, this column here, you can see is a 20% difference in untreated dental decay compared with the peers who live in a home-based community. So what we're looking at here is if you are living in residential care, if you are male, if you are non-European descent, if you are poor, all of these are important risk factors for difference in the prevalence of untreated dental decay. The risk factor of living in residential care has been illustrated by a number of epidemiological studies. And this study is one in Melbourne by Hofcraft and his colleagues, and identifies some of the key underpinning factors for those that are living in residential aged care settings. As you can see here, chronic conditions, numbers of medications, and whether or not you have got natural teeth or dentures are major influencing factors on outcome. So to summarize so far, the greater proportion of the population in most nations is rapidly aging. There are major declines in the proportion of older people with no natural teeth. Therefore, there are substantive increases in older people with teeth and with restorative dental care. And finally, there are substantial differences in risk to oral health in those older people with greater disability or who are living under different social and economic conditions. So let's turn now to looking at aging in health. Growing old is a natural and normal process. As we age, our body's ability to respond and withstand stress and physical challenge decreases. Our maximum cardiac rate decreases, as does lung capacity and muscle strength. As this Australian data illustrate, as we age, we also accumulate more chronic diseases. As you can see here, the numbers of diseases by age group across here. So that by the time we are 65 years of age, we may have accumulated 2 or more serious medical conditions, and just under 10% of the population may have 3 or more systemic health conditions for which they are being treated. In the Australian context, the major chronic diseases are cardiovascular disease, cancers, mental health disorders, diabetes, respiratory disorders, musculoskeletal diseases, chronic kidney diseases, and oral diseases themselves. So in the next few slides, I simply want to illustrate the prevalence of these conditions in Australian elders. Deteriorating sight, arthritic conditions, hypertension, and respiratory diseases. And these conditions are treated with drugs in such a way that many elders take more than 6 medications per day. Our definition of disability means that your normal daily activities, such as walking, dressing, shopping, and even brushing your teeth, are compromised on a daily basis. More than 56% of older Australians report a disability, and almost a quarter of them have a severe or profound disability. As you can see here, although it's a little bit more difficult, common musculoskeletal conditions also can have a direct impact on oral health. They limit the capacity for a person to grip, as you can see here, to grip and handle a toothbrush. Getting someone with arthritis, a condition like this, to manipulate dental floss or some of the fixtures that we use is very, very difficult. An Australian productivity report documented the increased rate of disability with age and also noted that the increased prevalence and burden of dementia and other cognitive conditions with age. This is very sobering, that between 37 to 47% of all very old Australians report a disability that in the form of dementia or Alzheimer's, and these are the diseases which at this point in time we can do very, very little about. Focusing a little bit more on the relationship of aging to comorbidity and multiple drugs brings us also to the concept of frailty, the geriatric syndrome, and the impact that these conditions have on a person's capacity to make decisions about oral health care and about dental treatment. This slide summarizes the relationship of many of the conditions, as you can see here, that are associated with the cognitive, with geriatric syndrome and frailty. There are shared risk factors, such as chronic diseases, cognitive impairment, pharmacotherapy. All of these contribute to these main elements of the geriatric syndrome: incontinence, falls, pressure ulcers, delirium, and just functional decline overall. If you think through these collective issues in relationship to your dental patients, you will get a better understanding of their physical, mental, and social capacity to respond to dental care. People who are frail are very vulnerable to rapid deterioration in their health, should they be challenged by trauma, by infection, or shock. So in the next two slides, I'm just going to quickly go through a refresher. Oh. Hello, Shaju. Let's get back on track here. These are the summaries in these next two slides. These are normal changes of aging, and they're probably found in any current textbook on geriatric dentistry. I've taken these from the Lamster and Northbridge textbook called Improving Oral Health of the Elderly. The first thing to remember here is that the impact on the biology of oral tissues with age and some of the key medical and health conditions which may impact on dental care. For example, you should remember that oral tissues are also more fragile in older people and often less responsive to clinical interventions. In this particular chapter of this text, there is a real good coverage of the conditions, the medical conditions that can impact on dental practice. Increasingly, however, when you are called upon to provide dental care to an older person, medico-legal aspects must also be at the forefront of your treatment planning and discussion. A sound medical history and understanding of your patient's capacity to understand what you are going to provide to them, the nature of the disease, looking at their medical histories, before you find the correct range of treatment for that individual. The most important concept here is the individual's capacity to provide informed consent. If you don't have informed consent, then there are some real legal issues about the care that you deliver. If there is any doubt about an older person's capacity to understand the dental care you wish to provide, then you must seek advice from the person's legal guardian. Moving to the more direct impact of certain conditions associated with aging and the prevention of oral diseases, I wish to briefly cover three issues. First, the important role that saliva and diet play in prevention. Second, the need always to look at an individual's personal capacity for care of themselves at home on a daily basis. And third, on using a variety of aids and products to support those with limited capacity. We often forget that diet, bacteria, plaque, and saliva can change rapidly with older people with different health conditions and with different medications. This slide simply illustrates that with different medical conditions and drugs, saliva flow rates can be seriously lowered. The pH of saliva can be reduced dramatically to demineralize both teeth and certain types of restoration, and that the buffering capacity of saliva will also be reduced, adding a further risk factor to dental care. These data are taken from residents in the 11 aged care facilities that we look after in Sydney here. They show that 2/3, these two in this column here, these two amounts, these two figures show that almost 2/3 of residents in our aged care facilities need either full or partial assistance with their daily oral hygiene. As our populations age, the capacity for the most vulnerable of our older citizens to maintain their oral health will decrease. And we have to look for better ways to assist them in maintaining an enjoyable and safe quality of life. And this has to occur on a daily basis. There are a variety of simple things that we can do and products that we can use to assist. But one of the most important is ensuring that we use the full range of our dental team, including dental hygienists and oral health therapists, to assist in aiding our older patients on a daily basis. So we've got simple devices and we've got complicated devices, but the most important element is to use our personnel, such as dental hygienists and dental therapists, appropriately. Technology, the good and the not so good. Just want to run quickly through some of the dilemmas we are faced with in the dental practice and how modern technology can be either a burden or a value to older people. We have a tremendous range of adhesive and restorative products at our disposal. One of the most rapidly growing areas of dental technology relates to implants, from single teeth implants through all-on-4 denture implants to total reconstruction of both dental arches. The question in treatment planning for an older person is not so much what we can offer and what we can do now with all this wonderful dental technology. It is a question of should we be doing it? What should we be offering? Here are a few examples I've downloaded from Dr. Google on what can go horribly wrong when we inappropriately apply aspects of modern technology in situations, especially on our older patients. This slide is taken from the work of Dr. Ronald Ettinger from the University of Iowa. Dr. Ettinger makes the point that dental implants can be a valuable clinical intervention, but if the patient is medically compromised or does not have the physical or cognitive capacity to meticulously care for their teeth and mouth, then peri-implant inflammation can lead to infection and aspiration pneumonia. This very recent publication by Dirks and his colleagues on data from the Swedish Dental Service is again very sobering when one considers implants in older people. After 9 years, 77% of people with implants show some degree of bleeding on probing or suppuration around the implant. Almost a third had at least one periodontal pocket 6 millimeters deep or more. We need to very carefully think through the risk and the benefit of implants for our older patients and ensure they and we understand the consequences of biological and normal aging on their prognosis. Notwithstanding the potential downside to some aspects of dental technology, we have a great range of materials, and I'll pick up on some of the clinical preventive materials shortly, and equipment which can make access to dental care for home or resident-bound people a lot easier than a decade ago. We can easily now transfer a lot of core diagnostic, preventive, maintenance and emergency care to residential aged care facilities or into people's homes. And these are just some examples of portable dental equipment. Modern portable dental equipment is allowing many private and public dental practitioners to take their services into aged care facilities and to community outreach programs. So when we now consider the range of frailty and dependency of our aging populations, we should be thinking in terms of how we can maintain the continuity of their care over their lifespan. While the majority of older people will be able to come to our office and surgeries, there will be an increasing number who are vulnerable and frail and will require support in maintaining their teeth and oral tissues in later life. Without continuity in care, we can end up with situations like the following. Here we can see implants to retain an upper denture but no maintenance. A partial lower denture with root caries surrounding the lower teeth. And this is an 85-year-old in the residential aged care facility. He has a raft of medical conditions impacting on his oral health, and he has been admitted to hospital for acute cellulitis. This is a 95-year-old resident with a long history of dental care, but who has not seen their dentist for over 5 years. She had 4 acute abscesses and little capacity to maintain oral hygiene on her own. We will increasingly see more cases like these two, and we need to change our professional practices to think more seriously about how we and our patients can maintain their oral care, what assistance they may need on a daily basis, and the role of prevention, diet, and saliva in the settings they reside. There are a range of oral health information or toolkits available in many nations which address prevention and oral health promotion for older people. And these are the things that we should be addressing across the region. This is an example of one of the Australian oral health toolkits for older people, with simple messages on daily prevention, which are evidence-based, but specifically targeting the needs of older people, of nurses, and also of aged care facility staff. Most of the Australian oral health promotion materials for older people are based on the Australian Government Better Oral Health and Residential Care Program. You can Google this and get access to this program directly. This program provides written and online materials, education and training programs to more than 2,800 aged care facilities throughout Australia. It provides training modules for staff on 6 simple daily preventive interventions. And we'll have a look at these a little bit more detail in a minute. As part of this program, it includes training nursing home staff and doctors to recognize anomalies in the mouth. There are a series of check boxes here are provided to assure a systematic approach to looking around the mouth by the nurses, by the carers, and by the doctors. This is called the Oral Health Assessment Tool, a very simple way of checking on residents' oral health. As shown here, the main preventive and daily interventions include a simple toothbrush, a soft toothbrush, a high fluoride toothpaste, a spray for those with dry mouth, and a chlorhexidine toothpaste to reduce oral bacteria. The schedule for the use of these products within an aged care facility is put on to a poster like so. So it's very, very simple for nurses and doctors to follow on a daily basis. As you can see here, brush your residents' teeth twice a day, use a high fluoride toothpaste, use a soft toothbrush, use a toothpaste containing an antibacterial after lunch, use and drink water to keep the mouth moist, and cut down on sugar. Dental care for older people involves the full dental and health team, with the patient as the center of the activity. It's patient-centered dentistry. The next 2 slides look at what we describe as best practice in aged care. This is a summary of an international workshop held in Seattle in 2012, which was subsequently reported in a special issue of Gerontology in 2014. The slide summarizes the findings of a workshop across 2 axes. Here we have dependency across this axis, no fully functional, pre, low, medium, and high dependency, and on the y-axis here, the 4 types of intervention: assessment, prevention, treatment, and communication. I think this matrix gives some general pathways for dental practitioners to consider for the diversity of older people who require dental care. Now, treatment options for older people with different levels of dependency, you can see the variation in pathways to consider. So it takes you through a variety of different approaches in each of those particular areas, and it's well worthwhile having a close look at. The second guiding principle document comes from the 2012 American Geriatric Society. They published a 5-point set of principles for clinicians dealing with older people. The key elements were, firstly, always listen to your patient's preference for care, especially those who have got a number of comorbidities or are on a number of medications. Always remember that our evidence base for much of the treatment that we do is not specifically developed for older people, and it therefore requires careful interpretation before we apply it to older people. And this goes for a lot of the restorative work that we do. most of the age groups that the implants have been, and crowns and bridges and sophisticated dental technology has been developed on and tested on have been for younger, middle-aged, and not necessarily older people with a number of comorbidities, or on a number of drugs. Plan and treat older people on the basis of the risks and the benefits, and of the prognosis and expectancies of the older person and their families. Consider the most simple and practical clinical options for older people when making decisions. And finally, use only those strategies that have beneficial, are not harmful, and will enhance the patient's quality of life. To summarize the key points, recognize the diversity of health and wellness of older people, understand the link between oral health and wellness of older people, look at the changing medical and health needs, listen to older people, slow down, and appreciate their contribution that they have made to the lives of others. Focus on quality of life, prevention, and support. Make sure that your support and reception staff, this is a very important one, make sure that your support staff, your reception staff understand the needs of older people with disabilities and cognitive impairment. The focus should always be to improve the quality of life of older people. In summary, I've tried to take you on a journey through the demographic changes that are occurring in all aspects of the world, and looking at how aging and health relate to oral health needs and demands, and recognizing the limitations of much of the newer dental technology which is available, but perhaps may not always be suitable for our older patients. Finally, focusing on matters of importance to older people, problems, maintenance of their oral health, and enhancing their quality of life. Thank you. Back to you, Shaju.
Thank you, Prof. It was a very nice, lucid, clear presentation. And I think you highlighted almost all the aspects which we should be worrying about or taking care when we design policies for our elderly, including what I was impressed upon, what you had simple messages wherein the nurses and doctors who take care of the elderly on their other ailments should also have some simple messages which can reduce the oral disease burden in them, than truly focusing on dentists for each and every. At least the preventive care can be done by the other professionals too. So I think elderly care would be a huge topic for someone to understand, and from you, it is a very lucid presentation, right, Prof? I think we'll have questions, but we'll have these questions at the end of this Dr. Rahul's presentation, so that we can ask the questions asked by the participants. I think now it's time for Dr. Rahul to come in. So thank you, Prof. I'll cut your video now.
Pleasure.
And then yeah, I'll make you join during our Q&A session with Dr. Rahul.
Okay, thank you very much, Shaju, and thank you very much to your participants.
Okay, Prof. Please be with us. Thank you. Dr. Rahul Nair is basically from India, and he has experience in Singapore, and he's currently doing his PhD in Australia. Dr. Rahul, please correct me if I am wrong in any way, because I tend to make mistakes always. He has graduated from India, from Manipal Academy of Higher Education, then did his MPH from Western Kentucky University, USA. He is an MS in Dental Public Health, and I believe he's right now a PhD candidate in Australia, an Australian Research Centre for Population Oral Health, Adelaide Dental School, Adelaide, Australia. He has been worked as an assistant professor in the famous NUS, National University of Singapore, where he developed and directed courses on research design and evidence-based care. He has mentored several master's students. His expertise includes in quality of care, quality of life, econometrics, and evidence-based care. His interests include population studies on elderly and children with autism spectrum disorder. The topic he is going to delve is a measurement of oral health among elders in Singapore. This, basically, which I understand is based on his 4 studies or 4 population-based studies which he has done in Singapore. And now I give the floor to Rahul. Please, Rahul, please welcome to our conference.
All right. Perfect. Yeah, it's coming now.
Yeah, good. Thank you. Bye.
Thank you for that introduction and for giving this opportunity to share some of the work that we did in the past. So today I'm going to talk from a slightly more global perspective on measurement of oral health among elders in Singapore. And what I mean by that is a lot of times when we think of what should we do about care of elders, from a public health perspective, from a programmatic perspective, we might try to make some decisions on where we should go with this. And measurement is one of the things that is sometimes not thought of that much. And so I'll try to bring that perspective in today. Yep. So I'm going to measurement needs and instrument availability that is there. I'll talk a little bit about free living population and a few things that we looked at, including quality of life, willingness to pay, and xerostomia. And in the institutional side, we looked at nursing home staff. And I'll conclude with some perspectives on the results and on the needs and the research needs. Now, this is, I think, going to be a trend that we see with any presentation that we see for the elders. So we see that increase in the number of elders, especially those who are over 80, and we see that for pretty much all regions around the world. And obviously, more important in this scenario for my presentation is the demographic trend for Singapore. So what is that going to be? In 2005, Department of Statistics in Singapore made a projection that by 2030, we're going to have about 18.7% people who are older than 65. Now, when they made this in 2005, it was a long stretch, and we'll see if that is true, or if that is going to be true. But what is it now? If we look at this trend here now, you can see it probably is around 11, 12, somewhere there. And when we look at it, the current data, then we see that clear increase. So look at the right side and what is happening here. And if you look at the right-hand side of it, then you can see the 6, 7.2, 9, 11, and 12.4. And you can see that straight increase, probably a little bit more of an increase than was predicted in 2005. So we could say that they are sort of on target with what's happening. We can see the same trend when we look at it from the perspective of which population group among women and men at different age groups are going to be increasing. So something that we can see quite easily here is that you can see the 60 to 64 and 55 to 59. Those groups see a very large increase, and they are going to be coming in over the next 10 or so years into this older category. So we can see some rather large changes that are going to happen and continue to happen in Singapore. And this is probably something that is going to be seen in most countries around the world. Now, let's take one other look at something else. I hope everyone can see this. If you look at the last column, all that we need to look at is the last line that is there, which is 107, and the first line, which is the total. So what is this saying? This is saying that if you have 65 and over, a large proportion of people may not be working at that age, and which means they may not be earning anything. So that sort of brings in a little bit of an economic perspective to what is and will continue happening probably in more numbers in the coming years in Singapore. And among the living arrangements, we see again we have a few categories here. But if you look at the last line here, we look at other living arrangements. And what other living arrangements shows us is that between 2005 and 1995, we see an increase. And this could be a whole lot of different things that are there. But some of them is something that we'll look at in just a bit. So just keep in mind that there is an increasing trend of people who are not living in the usual household situations that many of us might be in. So what are the key settings that people are going to be in? So the easiest one is the non-institutional group. So the non-institutional group is like you and I, probably in a free living community. There are going to be some who are in community homes. These are supported homes that have large groups of people that are living together. Besides that, you have the institutional group with intermediate and long-term care as well. So for the institutional, you're going to have intermediate care, meaning they can stay there for up to about 2 months. So that's going to be if somebody goes through a cardiac event or something of stroke or something like that, and they need rehabilitation, but they can go back to a free living situation. So, and the long-term care is for people who need to live in a place for longer than 2-3 months or so. So looking at this now, we had to sort of decide what are the things that we need. If we decide to spend a few years building up on our knowledge base, what should we build it on? And that is sort of what we will look at here. So what should be our research and programmatic measurement needs? And by measurement here again, we are simply talking about all the things that we need to measure so that we know where we are going and what are we doing. That's about it. So it could be anything. It could be measuring caries. It could be measuring other things using questionnaires, and we'll talk about that right now. So the key outcome measures that we picked trying to think of where we should go with our research perspective. So these key outcome measures were probably are probably one of the most important things that we can think of. So why are they important? Let me first bring them down, and then we can talk about the overall perspective. So among disease outcomes, as Professor Wright rightfully pointed out, xerostomia, lack of saliva, is an important one. We thought that was something that should be measured well. We've got oral health related quality of life, meaning how much, if we have to measure how much does a disease impact a person, then these sort of measures are important. And finally, willingness to pay. That is the last one. And let me just bring an overall perspective to all of this. If we want to know where we are going as a society and as a community, then we need to know what are we trying to achieve and what are the measures where we should have some sort of a change. So we, from clinical practice, many of us who are clinicians probably recognize that there are a lot of people who don't care about a missing tooth, or who don't care about even a cavity or a tooth that is loose. these things don't always impact on increasing a person's need. And if that is the case, we need to have some measures that try to figure out what matter to people. If healthcare is about people, then we've got to make measurements that matter to them. And so from that perspective, we decided that we are going to look at things that are patient-centric. And from patient-centric perspective, we made this short list. Besides these, obviously, we did a whole bunch of measurements that include caries assessment and other measurements, perio assessments, those types of things. So I'm going to talk from the perspective of 4 or 5 studies that are there. I'll go through 4 of them and sort of capture the 5th one in some conclusions. So from that perspective, the first one is looking at the reliability and validity of a quality of life measurement called oral impacts on daily performances. We did some cross-cultural adaptation, construct validity, internal consistency, retest reliability. I'm not going to go over the details of the validation process. Perhaps that is less important. What might be more important is the actual results. So just to give you an idea, we had some people who were between 65 and 99 years old. The median age was about 75. About 19% reported some sort of a problem in their mouth. Cronbach's alpha was 0.75. Internal intra-class correlation was about 0.75. Probably not super important. But if we look at whether these measures agreed with some other measures that we did, it seems like they did. Some global measures of quality of life. We try to see if this measure is working the way it should within a local community. And since these were not made in Singapore, we try to check them. And it seemed like they were all agreeing. They all seem to be doing well. Now, what mattered the most among self-reported conditions? Among self-reported conditions, people really were worried a lot about tooth loss. They worried about ill-fitting dentures, sensitive tooth position, toothache, receding, and very few cared about swollen gums. This is something that we probably can rationalize quite easily based on some clinical perspectives that we have already. Again, we look at percentages of oral impacts that are applicable to self-reported conditions. And let me explain what that is going to be. So what this means is the quality of life measure asks about all these things on the left side. So you're looking at eating, speaking, cleaning, sleeping, relaxing, smiling, emotional state, and enjoying. Among these, you can see that eating and enjoying contact were probably the more important ones, since they have the largest percentage of hits because of problems in the mouth. Besides this, people also had trouble with speaking. People also had trouble with their emotional state, meaning they felt disturbed. They also had trouble with smiling, laughing, and showing teeth. I mean, once in a while we wonder whether dentistry matters and where does it matter. And in this case, it shows us that this is where some of it mattered among this group in Singapore. Again, for eating, you can see tooth loss, ill-fitting denture, toothache, receding gums, and you can see that sort of a pattern there. You can see tooth loss is reasonably important for most things. There were a few other things as well. Eating, obviously, ill-fitting dentures, and obviously is a matter of perspective, but here we see some data on that. Now, moving on to something a little bit different. So we know that quality of life matters. For people, that is probably what matters more than did they lose a tooth or do they have a cavity, those types of things. More than that, they care about what impacts them and their overall well-being. So we wanted to see how this links with how much they are willing to pay for various interventions. Now, in this case, we use something called willingness to pay. Willingness to pay falls under a larger category of things that looks at economic well-being. economic balances even. So it comes under the a blanket of things similar to you've got cost effectiveness, cost benefit, and cost utility, and this comes under cost benefit. So what it does is it weighs all the harms and benefits and puts it together with some costing and gives you some results. That's what it does. It weighs the costs and benefits quite well. In this case, we wanted people to value how much they would pay for extraction of filling and cleaning of teeth. And what we found was, if we asked through trained interviewers using a method called a bidding method, where the cleaning, filling, and extraction were the prices that are given there, 80, 80, and 50, then we find that there are a few things that matter. So first of all, let me take you straight to, there are 3 places where you have OIDP score. You can see it here, here, and here. And in all 3 cases, you can see that it approaches statistical significance. What does that mean? It means that in some situations, these two may be related, not always. We had some power and sample size issues here as well. But besides that, what else mattered? Now, if we look at it, then we can see that age mattered here for extractions. You can see age again matters here, and again here. Now, in the ethnicity, there was a group that were Tamil who were willing to pay a little bit more, but there might be something happening in that data, and we should recognize that, because if you ask people in a language, then that can matter the measurement, and so we will take that with caution. So let me bring it back to what the result means, that if OIDP, which is the quality of life, and willingness to pay are related to each other, what we saw was a trend where a higher OIDP score was related to lower willingness to pay. Meaning, if your quality of life is bad, you are willing to pay less to get a fix for it. And that is counterintuitive. Why would that happen? Why would people who are in trouble not pay for getting out of it? And that is something that took a while to figure out. Now, in the Singapore context, we have something called CHAS, or Community Health Assist Scheme. What it says is that if your annual income is below 1,800 or 1,100 Singapore dollars, then you get some assistance. Your treatment is heavily subsidized. In this case, we found that some of the people may not be willing to pay that and may need even higher subsidies for that. And obviously, this does not mean that CHAS is a bad scheme. And the reason we can say that for sure is because a lot of people are using it already, though we do not have concrete figures on that. But we unofficially know that a lot of people are using CHAS, but maybe some people who are in trouble may not be using it. And that is the takeaway from that one. Now, we looked at quality of life. We looked at willingness to pay and what happens when quality of life is worse and how much people are willing to pay for treatments to get out of these. The third thing that we're going to look at is xerostomia inventory. So there is this 11-question questionnaire that was built here in this institute and later in New Zealand by Professor Murray Thompson. And we use that for measuring xerostomia. So xerostomia is the subjective feeling of dryness, whereas salivary flow is the actual flow rate. We did some regular steps that are used for validation, and we collected saliva using chewing of paraffin for over 5 minutes. And what we found was a very low salivary flow rate among about 300 people that we tested. And to the point where 32 participants had no measurable saliva, absolutely dry mouth, according to our measurements. We saw that our instruments worked reasonably well, meaning these could actually measure what was happening in the mouth. and the translations were working properly. And that's what these say. And I'll sort of hurry across this slide to the next one because that's probably where it is a little bit more interesting. So we find that the shortened and the longer versions were related to quality of life again, meaning people with bad xerostomia in Singapore also had worse quality of life measures, meaning they actually thought it impacted their lives quite a bit. Similarly, global quality of life scores were also related to xerostomia inventory. Salivary flow rate was also related, as can be expected. So, and now coming to the overall picture that we saw so far. So we saw that we looked at disease outcomes, quality of life, and willingness to pay. We linked quality of life to xerostomia and willingness to pay. Now, the next thing that we're going to do is we're going to look at institutional group and see what happens in an institutional group. In an institutional group, probably one of the low-hanging fruits is looking at the caregivers. And we wanted to see how are the caregivers doing. In this case, what we did was we looked at investigating perceived behavioral control and attitudes for the caregivers. We did this based on theory of recent action, one of the psychological theories made in 1975, and we used a questionnaire, and we built the questionnaire using usual methods. We did a couple of validation, and then we try to see if this works properly. After that, we figured out that if you are trained versus untrained, some of the things changed and some didn't. So this is a bivariate analysis, meaning there is no regression or anything fancy happening here. So what we are seeing here is that you can see that the attitudes and subjective norms were significantly different, but not perceived behavioral control. Perceived behavioral control, for anyone who is interested, is something sort of like self-efficacy. I think self-efficacy is something that many people may be used to. So this is very similar to that, and that is sort of a little bit important. So when we look at a larger regression analysis, then we see that now you can see that there is a significant difference. So what does this mean? It means that perceived behavioral control can be improved if the caregiver gets training on the job. That's what this suggests. A little bit of caution here. We say that training seems to improve perceived behavioral control, but this does not actually mean they did something about it. So they may have more control for cleaning the teeth or checking the dentures or things of that nature, but these nurses and other caregivers may not have actually given that. And that also depends on number of residents who were under their care. And it also depends on gender in this case. So if you are male, you are less likely to have perceived behavioral control. Again, with the gender, we'll probably take it with a little bit of caution, partly because there were very few men who were in the study, so there might be some skewing based on that. Now, to draw some perspective on these results. So we have to take a measurement perspective. We've got to see what went right and what went wrong here. So from that perspective, we kind of can take the opposite view as well. Though all these worked, many people who had clinical diagnosis of caries, missing teeth, periodontal disease, did not have impacts on their oral health related quality of life, which means we had a diagnosis, but they had no problems with that. And I think this goes in very well with some of the slides that Professor Wright had earlier. Similarly, those with low oral health related quality of life also had low willingness to pay, meaning some people may not see dental care as the solution. for some of their problems. So we should be a little bit careful about that. Lastly, low salivary flow rate did not always result in impact on xerostomia inventory or on oral health-related quality of life. Meaning, people may have dry mouth that we are measuring, but they may not feel that that is trouble. So if that is the case, then we have to sort of try to figure out how to adjust their management and how to deal with their management appropriately. Overall, a need for caution. Anyone who has been in public health for long would have seen the first paper by IMUOHS. IMUOHS says that most published research is wrong. A very contentious claim. There were about 4 replies to his article that came out, and all of them were saying, yes, most of it probably is wrong, but something or the other. And in this case, the reply that I quote here along with it is, a replication or repetition goes a long way. The reason I brought that up is because for pretty much all research, including the one that we are presenting, replication is required before we say that this actually works the way it does. Thankfully, some of our results were in line with some of the other studies that are out there. So probably some things are reasonable, but still we should be careful. The second one is the Wright Care series by Lancet. By the lead author Vikas Seni, who is in an institute in the US. What he is talking about and their team is talking about is where we give care more than required or less than required, under or over treatment. And that is what the Wright Care series is about. The reason I brought that up is because we need really good measurements to know whether we are doing the right thing. And from that perspective, we need really good measures, and that is probably the reason why we spend so much time trying to make all these little things, including the quality of life, the xerostomia inventory, and the other inventories that we have tried to validate locally. So kind of keep in mind that there is a large chance that we can be wrong, and that much of the care that is out there in medicine and healthcare overall may be a mismatch for what is actually needed for the patient and the patient's best outcomes. And so we would say that patient-reported outcome measures, such as quality of life, that were built in places that were very different from those in the multitude of values that we have in Asia, should be taken with caution. When we do cross-cultural adaptation like what we did, then when we have various languages, we don't know if score 10 on in Mandarin would mean the 10 on English. Those two may not add up. So comparison between the two may be a little bit more difficult, and we should be careful. The meaning and limitation of instrument validation and cross-cultural adaptation is something to keep in mind. Again, so when we take it from another place and we implement it in our situation, it doesn't just work. These are not supposed to just work, and please be cautious of those. So need for future. I think I'm talking sort of re-emphasizing some of the things, appropriate patient-centric outcomes and reporting valid patient-reported outcomes. So if you do a program or things of that nature, then make sure that we know that people are better off at the end of this. We need really good design and analytics to minimize the risk of bias. And replication of such interventions need to be done at scale so that we know if it actually works and if we can actually benefit more people. I would like to thank and acknowledge my good friend Robert G, who he and I worked together on pretty much all the things that I just talked about, and Ministry of Education Singapore Tier 1 grant that funded much of this. And thank you.
Hi, Rahul. That was a good presentation. It's unfortunate for me that I couldn't view the whole thing, but I was impressed. Hi, Rahul. Can you hear me?
Yes, I can.
Yeah, because I was checking whether my voice is coming through
Oh, it
or
is.
not.
Yep.
So I was impressed by this, where you said that the quality of life which the person perceives need not be related to the dental needs as we perceive for the patients, as we caregivers the patients. That is the important point we have to take home in this thing, that patient comes first.
Yep.
As we perceive that they are in trouble, if they are not in trouble, as they say, we should respect their autonomy and their respect to life.
Yes.
And And second thing I was left worrying is, as you said, you put your Lancet paper. The Lancet paper said that all the research evidence are false, or most of the research evidence are false. Might be true because history will tell us whether the research we do is really true or not. Whether any changes we made, did it make a difference? That I think would be told by history. But this might be too far-fetched because many things which has been research-oriented changes has found a benefit for the community at large. So I'm not sure whether it is an empirical paper which has said that they compared the research evidence and then the replication of it, or did it take into account whether the benefits has been come into the community at large. So it is a top of debate.
I can clarify on those two. And the first one is, thank you for bringing that up. The first point about whether the patient comes first or our opinion. I think our opinion might be a little bit more important in places where the prognosis matters. Like, for instance, if periodontal disease is going to make diabetes worse, and we can, I think, give a little bit of perspective on that, and that sort of matters. But in other places where that may not be the case, where prognosis does not impact in any way, probably patients would matter. The second one, where you brought up the thing about most research being wrong, I completely understand that we are better off with research that we have so far. I don't think we should ever take away from that. Otherwise, I wouldn't do research. I think I should give it up. So I do not intend to go that far. But all that I'm saying is we should be really cautious when we use research, especially from designs that are not optimal. So, and that is about it. And sometimes we don't have optimal things, and then we are uncertain, but we have to do something. In clinical situations, there are many times when we don't have optimal things, but we just have to make do with what we have. You're right. And we are better off than we were before. That is also true. Yes.
Prof. Wright, you have any comments for us?
No, I've got nothing else. I thoroughly enjoyed Rahul's presentation. Thank you very much, Rahul. I've had one contact come through on the chat line, and perhaps Rahul would like to have a go at answering this too. It's a question from one of the participants. Does low saliva flow in the elderly mean more infections in the oral cavity? Now, I mean, I think there is, in the quality of life issue, there are some disputes there, but certainly from our medium to high dependency patients, and especially those that are in palliative care, low saliva flow rate can be very distressing. It can also, I believe, lead to a lot of oral health, mucosal and periodontal problems, as well as making it difficult for denture wearers. But I'd really enjoy your comment too, Rahul.
Thank you. I agree, Prof. Wright. I think prognosis, maybe prognosis and impact on somebody's life might be two slightly different things. And in the case of prognosis with low salivary flow, depending on whether it is low salivary flow from the mucosal serous or which gland groups are affected, maybe there are some impacts that are very specific to those, and that should never be discarded or not considered. Yes, and there is a much higher chance of periodontal caries, infections, other mucosal infections. Yes. So low salivary flow rate is associated with them.
Yeah, thank you, Prof. And thank you, Rahul.
Thank you.
That was a question which was asked by one of our colleagues, Dr. Sunil. He's a pathologist here, so he was more interested in asking. And thank you for bringing it up, because we had noted that question. Does low salivary flow is responsible for more infections in salivary? And I think one more question we have in the chat room, I'll just read out. Xerostomia in elderly is due to the age or merely due to polypharmacy or polymedications? Or is it because of the medication, or is it because I grow old, I'll have definitely low saliva? Is it like that?
Yeah, somebody's been asking difficult questions there. That's a tricky one. It really is. Certainly we can say very definitely related to polypharmacy and medication. And the evidence, I think, on whether xerostomia or dry mouth, as Rahul said, xerostomia is a perception, dry mouth is the observable, objective lack of saliva. I think you'd probably find that there's probably erring on the side of, yes, there is an age relationship, but it might be confounded by other issues. So there is some biology of aging that looks at salivary glands, the number of them, their production rates, those sorts of things, which indicates that age is a factor. But I think it's not the only factor, and it's very definitely a lower factor as compared with polypharmacy and medications. But over to Rahul.
I concur. I'm not sure if I could have said it better. It seems the evidence seems really muddy at the moment on only aging causing. That's difficult to study. If only aging caused something, because we have so many exposures, that is really tough to say. But we know for sure that polypharmacy or polymedication affect them. Thank you, Aruna, for that question.
Yeah, thank you, Nadevi. That's what I was wondering. On a perspective of study design, maybe a two group wherein a older age group with no medications at all, which is definitely difficult to find, where it can be compared with persons with multiple medications. So study design is possible, I believe, but getting a patient who's free of any medications might be difficult at the older age group. So I think xerostomia might be at this point could be more of medication related, as I understand from you, but also age can contribute a little to it. That's what I understood from your answers. I think there is none other. If you have any closing comments, you can make Prof. Wright and Dr. Rahul, and then I think we'll go to the next session at 11:30. Anything for your final say?
Yeah. First of all, thank you, Shaju, and thank you also, Rahul. I'd just like to make a quick hi to Dr. Callum Durwood, an old colleague and graduate student of mine who seems to be online. Hi there, Callum. Great to hear that you're part of this program, and congratulations to the organizers of this symposium.
Rahul, anything from you?
Again, thank you for inviting me. I think I really enjoyed the session. I enjoyed Prof. Wright's presentation. It was a good rundown through the clinical things that we should keep in mind that is easy to forget. Thank you for those toolkits as well. And thank you for organizing this lovely symposium.
Yeah, thank you, Prof. Wright and Dr. Rahul for participating and enlightening us. And just to add, Dr. Callum will be talking on dental leadership tomorrow from his Cambodian perspective. So we have him tomorrow. So maybe you could join us, Prof. Wright, to wish your colleague and maybe bombard him with difficult questions.
Look, unfortunately, I'll be traveling tomorrow. I'm going back to my homeland, which is New Zealand.
Yeah,
so I'll be there.
Yeah,
my apologies.
Happy Easter and happy holidays for you all. Thank you.
Thank you.
Thank you. Thank you, Shaju. Thank you, Rahul.